Hello, everyone. Thank you for joining us this afternoon for this week Power Series. We're excited for you guys to join us. We're going to continue to let people come in, and she'll be started in a few minutes. But welcome. And feel free to introduce yourselves in the chat as you guys come in. We would love to get to know who's all joining us today for our Power Series. Welcome, everyone. We have people introducing themselves in our chat box. But if you're just now joining us, welcome to this week's Power Series this month. I see we have people from Ohio, Austin, Texas. I'm here in Austin, Texas, Florida, UK. Thank you guys for joining. Vegas. And so we continue to let people join us. We should be starting in a few minutes. So yes, feel free to introduce yourselves in our chat box as we continue to allow more people to join us this afternoon. So you have people from Sacramento, Charlotte, Louisiana, more folks in Austin. So we're going to go ahead and get started with today's webinar. And people can continue to introduce yourselves in the chat as we continue to let more and more people in. But look, I just want to say hello to everyone and welcome to our webinar of the Power Series. We are excited that you're able to tune in today. My name is Tyreek Daniels. I am the founder and executive director of WhatsInTheMirror. We are a healing justice social movement that provides mental health awareness and suicide prevention to communities of color through art, advocacy, and affirming care, with a focus on women, youth, and queer communities. Today, WhatsInTheMirror is partnering with the Black AIDS Institute to bring you sessions linking race, gender identity, and HIV health and mental health in a way that empowers us and moves us to advocate for one another and ourselves. Today, I am joined by Maya Merriweather, and she is the BAI Senior Manager. And she's going to lead today's webinar around medical mistrust. And so with that being said, we're going to turn the session over to Maya's expertise. She will share a few words about today she'll talk about medical mistrust. And we're going to have a Q&A period afterwards, so please feel free to ask questions in our Q&A feature located at the bottom of the Zoom screen, and we'll have time to address them following the presentation. So without further ado, Maya.
Thank you so much, Tariq. Very happy to be here today. Good morning or good afternoon, everyone, depending on where you are joining us from. As Tariq introduced me, my name's Maya Merriweather, and I'm the Senior Manager of Special Projects over at the Black AIDS Institute. Today, we're going to dive into medical mistrust a little bit. All right, so before we get into the actual meat and potatoes of this presentation, I just wanted to share with you all some shared agreements / ground rules for this presentation. So we will be able to create an atmosphere of learning, reflection, and commitment. So you're gonna have the opportunity to participate in the Q&A and also the chat box too. Feel free to communicate with each other using that. But be sure that you are speaking from your own experience, use I statements, don't project onto others, share the air. If you are taking up a lot of space, be reflective of that and maybe make space for other folks. Avoid making generalizations. So we don't want to treat people as a monolith or talk about groups as a whole. Oftentimes that means it's probably based on stereotypes, so no generalizations. Consider your own position and power within this conversation. Medical mistrust is a topic that we cannot talk about without at least touching upon the sordid history of Black folks in the United States as it relates to slavery. And so your identities and your position and your individual position of power might come up in this presentation in some form or another. So be cognizant and reflective of that. On that same note, this is a pretty rough topic. We're going to talk about atrocities. You kind of can't if you want to talk about the United States history in general. And with that, I would say if you need a break, take a break. This is just me giving you a content warning that some of the stuff in here is going to be a little bit rough to get through. Ignore that, camera's off, but please do use the chat box and the questions and answer box so we can engage with you during the Q&A period. Curiosity over defensiveness. Please ask questions during the Q&A period, ask each other questions. There's a lot of learning that can happen as a group through the use of the chat box. Be open-minded to different perspectives. We want to hear people. Listen without judgment, be fully present, and also don't fear being wrong. We're all here to learn. All right. So, and if there's any other shared agreements you'd like to add or uplift, you can feel free to put those in the chat box too. So now getting into the content of this presentation. So by the end of this presentation, you all will be able to define medical mistrust and understand why it's a relevant topic. We'll have an overview of historical examples of medical mistrust as it relates to Black people in the United States. And then we're going to end with sharing some strategies to combat medical mistrust in our daily work and our daily lives. So to start off, we're going to just do a baseline sort of definition of medical mistrust. So medical mistrust is defined as a suspicion or a lack of trust in medical organizations. So where does this show up? Like, what do I mean by medical organizations, I should say? So I refer to that as systemic or institutional levels. So that means it's built into the fabric of institutions such as hospitals, the government. We've seen a lot of that, even looking at the COVID-19 pandemic, which we're going to talk a little bit about as an example, into healthcare organizations and the pharmaceutical industry. Medical mistrust also occurs at an interpersonal or individual level. So if you are interacting with doctors or nurses, pharmacists, in our field, HIV testers or caseworkers sometimes, as well as your family and friends, medical mistrust can happen at those levels as well. So medical mistrust, now that we sort of know what it is conceptually, what does it look like in actuality? Like, what is the result of medical mistrust? Medical mistrust leads to health disparities. It leads to delayed diagnosis and treatment of illnesses. It leads to the spread of misinformation. It leads to the delay of preventative care. And ultimately, all of this leads to poorer health outcomes and lower life expectancies. And we're going to talk a bit about in this presentation about how this medical mistrust has a hold or a greater impact on other groups versus other ones, those groups being marginalized folks, and namely Black folks is who we'll center in this presentation. All right, so, uplifting that point of marginalized folks have a more polarized relationship with medical mistrust, I just have an example of a study that sort of punctuates this. So the data you see here is just asking questions of how medical service delivery relates to folks of different racial backgrounds. So they have surveyed white folks, non-Hispanic Black folks, and I think Hispanic folks as well. So as you can see, when asked whether folks trust their physician, their health plan, or hospitals, the different racial groups did give different responses, and namely Black folks are giving these sort of more negative responses. Same when you look at how people feel about hospitals, so whether or not they're a place that people go to die, if patients should always follow the advice given to hospitals, being is the information you get there trustworthy? There's different responses for different racial groups, and also just people's general relationship to being in one. So are they taking this information and using it for good, or for data collection that has no indicator or relation to your health? Are you like an experiment? Again, different racial groups answered differently. And so this is sort of something that I think helps prove that medical mistrust exists. We see that people just have quite literally different levels of trust to medical institutions. All right, so although for the sake of this conversation, we're going to be primarily centering Black folks, I do want to note that medical mistrust intersects and also compounds with more than just your racial identities. So people have different relationships to medical institutions on more than the basis of race. So when we look at gender, this is also the basis of a lot of general discrimination, but also medical discrimination and bias. And the degree of medical mistrust someone has can be compounded because of their gender. When we look at the field of HIV, this is really highlighted and polarized when we look specifically at the health outcomes of transgender women, and namely transgender women of color, or Black trans women, who have a greater degree of medical mistrust, it's been measured, than many other marginalized identities. And so this is an example of transphobia, misogyny, and race sort of compounding to make this experience of interacting with medical institutions more challenging and less trustworthy than it is for folks of other identities that are likely less marginalized. So all this to say that intersectionality informs people's relationship to the medical institution. All right, so I just wanted to, you can feel free actually to interact in the chat, place your answers to this question here, but I just wanted us to stop and think about just kind of the terminology of medical mistrust. So my question to you is, does medical mistrust indicate the opposite of trust? Does it indicate the loss of trust, a lack of trust, maybe something totally different altogether, or a combination of these things? And how would you describe mistrust in relationship to medical mistrust? When I think about this, I think specifically too, when I think about how people talk about medical mistrust in the age of the COVID-19 pandemic, I don't think folks tend to think about maybe why Black folks or why people maybe have medical mistrust. It just sometimes comes off as, victim blaming, honestly, for the health disparities. But trust is something that you earn, right? And so thinking about maybe trust is lost, as something that has been lost, sort of helps me to frame and kind of, I guess, like want to rally around these health disparities as something that Black people did not cause or inflict upon themselves. So please, that's my 2 cents, but please weigh in the chat. I would love to hear what you all have to say, and feel free to interact with each other as I move through the rest of this content. All right, so we're going to frame medical mistrust with a historical context in Black America. So we are going to go all the way back to chattel slavery and sort of talk about how it has interacted with the health of Black people. So medical care was essentially rendered to save the lives of slave owners' property, not necessarily because people wanted or valued the lives of enslaved Black people. It was an economical, decision, essentially, to give enslaved Black folks healthcare. So when slaves were ill, they were oftentimes even accused of faking or being lazy. And physicians essentially were used to reinforce slave owners' diagnosis or decide whether the slaves were actually ill or deserving of treatment. And again, not for their quality of life or their health, but to based on like shared economic success. So many Southern physicians' profitability and support of slavery sort of put them in a position to render medical decisions, and quite clearly they were not qualified to do so. Illnesses were also weaponized against enslaved Black folks in many ways, namely including a way to justify them keeping people enslaved. So you may have heard of runaway slave syndrome or drapetomania. This was invented by actually a white doctor as justification for why an enslaved person would be disobedient, why they would disregard their master, and why they would run away. They actually pathologized this behavior as an illness because it just made no sense, that a hostage would want to, be rid of their captors and be free. So this not only was used to sort of like justify like why a slave might run away, but also it was used to justify cruelty, further cruelty towards enslaved folks. And the cure for drapetomania, of course, was harder work than slaves were already accustomed to, as well as physical torture. So when we talk about medical mistrust, we cannot ignore the fact that our modern day healthcare institution was largely built on the backs of enslaved folks. Quite literally, their physical health is what led to a lot of discoveries and treatments and things like that are still in use and even like celebrated today. So sort of the hallmark example of this is the father of modern gynecology, J. Marion Sims. So he is celebrated today still in some spaces because he created the first successful treatment for vesicovaginal fistula. And so that's an abnormal fistulous tract. It's extending between the bladder and the vagina that allows for continuous involuntary discharge of urine into the vaginal vault if it is ripped or ruptured. He also did the first successful gallbladder surgery. However, he violated every core principle of ethics in medicine in doing so. This is why. So essentially, the research that he conducted, him and many, many other folks, was done without the consent of Black folks. And slaves did not even have the ability to consent at that. There's like always this power dynamic where if you are an enslaved person, you can't consent to anything because you are a hostage. And so the Western Medical Research Institution was, like I said, built on the backs of many enslaved Africans. And even though there were medical ethical standards in this day, they did not apply to Black folks. So sort of in this picture here, this is depicting J. Miriam Sims, and one of the names of the many, one of the few people who we know the names of, Anarcha, who he experimented on. Anarcha is sort of the best documented example of experimentation on enslaved people. And she was forced to undergo 30 gynecological surgeries, again, without any kind of consent. And so this image here, I think, is a great representation of how sort of this history has been erased almost completely, and the parts that aren't erased, very, very sanitized. So in real life, likely what this picture would be is Anarcha would have been totally nude. The enslaved women you see peeking around the corner would likely have been holding her down as she endured these experiments without any kind of anesthesia or pain aid. And in general, there were a lot of other enslaved women who had these operations, but we kind of only know the names of Anarcha. There's another woman named Betsy and Lucy, who were brought to Sims for the purpose of experimentation, and how he sort of made these developments and discoveries. So even after all of these atrocities happened to these women, Sims did go on to practice medicine in New York City and in Virginia. You also might be familiar with the example of Henrietta Lacks, who was in 1951, a Black woman who was diagnosed with terminal cervical cancer. Without telling her, the doctors at Johns Hopkins University snipped cells from her tumor, which were then kept alive. And then since then, scientists found that they could reproduce these cells indefinitely. So these cells are essentially in circulation today. They've been used in radiation studies. They've been used to test the polio vaccine. Meanwhile, Henrietta Lacks's family had no idea that this was happening. And they were, not compensated or anything like that for the use of Henrietta's cells. So another food for thought question. So as we sort of see, like a lot of these like torturous, things that enslaved Black folks and Black folks in general endured did lead to medical innovation. So my question to you all is, how can we hold ourselves accountable, we being just like society at large or folks who engage in healthcare? How can we hold ourselves accountable for our sordid medical past and contend with it while practicing medicine in present times? And this picture is also, so there's lots of monuments, there's buildings named after J. Marion Sims, medical colleges, things of that nature. Like he's still very much celebrated today. And so this statue, I believe, was in Central Park, and they're removing the statue of J. Marion Sims. So an example, more symbolic than anything, but an example of what accountability could start to look like. Right. So the Tuskegee syphilis study is another hallmark experiment. I'm sure many of you are familiar with it, but is the sort of pinnacle example of medical mistrust historically for Black folks. So the Tuskegee experiment began in 1932. 600 African-American men in Macon County were enrolled in this project, and 399 men with latent syphilis, the rest were a control group who were free of the disease, were essentially, well, I think I'll get into that next slide, but despite the fact that penicillin became recommended treatment for syphilis in 1947, some 15 years into the study, the experiment continued into 1972. So folks were essentially, syphilis was allowed to progress in these Black men for the sake of research, even though there was treatment available, which is a violation of ethical principles in medicine. And what happened from the study is 28 participants had perished from syphilis, 100 more passed away from complications related. And at least 40 spouses had been diagnosed with it, and the disease was passed to 19 children at birth. So essentially, like I said, this was the hallmark example of medical abuse in Black people in the United States. And why is that? The men were lied to and told they were receiving treatment for syphilis, but instead treatment was withheld. I think here it's important to note too that after the Tuskegee syphilis study ended in the 70s, the HIV epidemic actually started less than a decade later. So if you can think about, like, people have Tuskegee very fresh in their mind, how are people going to relate to this HIV epidemic and sort of like view the new informations and study coming out around HIV? Obviously, there's going to be a lack of trust there, resulting from Tuskegee. All right, so another question for you all to think about. So what can we do when the state has lost the trust of its constituents? So in the case of, we'll talk about COVID-19, for example, but also in the case of the HIV epidemic in the 80s, when the state has lost the trust of its constituents and even has a history of bait and switch tactics and deception to garner their compliance. Whose role is it to ensure the health of the people if the state cannot? Something to think about. All right, so we are going to get into just an example of modern day medical mistrust. So how does all this stuff that we talked about historically kind of relate to what we're experiencing today? So I think it's essentially not possible to talk about medical mistrust without acknowledging the COVID-19 pandemic, which has become a pinnacle example of it in modern day. So here I just have some of the ethical principles. Beauchamp's medical principles is who they are, listed sort of how they were applied during the COVID-19 pandemic. So if you kind of look at this chart, you'll see that a lot of it is in conflict with each other. Like giving priority to the worst off, does that mean the sickest or the youngest first? That changed a number of times during the pandemic. Saving the most lives versus saving the most life years, that feels in conflict with each other. And so I say all this to say that to me, ethics feel like a construct. And for me, that means, and we've seen that ethics apply differently to different groups of people. And I think that you can see sort of the results of this when we look at the disparities in the COVID-19 pandemic. And so just like looking at even the comorbidities that people have with COVID-19 and underlying health conditions and things like that, does the same code of ethics apply to that group of folks as people who do not have it, folks of different races, things of that nature? We see things like coming out in the news, such as like Black folks during this pandemic have, by and large, received less resuscitation attempts when it comes to that. And so, yeah, I think that this makes me question whether or not ethics are, like, who is constructing the ethics and how are they applied? I think that contributes to the sort of continuing legacy of medical mistrust in Black folks. So I did want to sort of highlight that medical mistrust is actually not always a bad thing. I think it's oftentimes framed as something that is detrimental to people's health, and not to minimize that, it oftentimes is. But I think that medical mistrust is also a form of resilience and a form of resistance. The graphic says we help keep each other safe, by the way. It got cut off a little bit. But I think that another alternative way of looking at this is that medical mistrust can actually empower individuals for change when it is channeled effectively. And medical mistrust essentially is adaptation, right? It's something that has helped us protect ourselves. It's a survival mechanism that we have sort of adapted and taken up in the face of oppression. And it's also a healthy and a valid response to when you have been deceived, over and over again. So just kind of reframing medical mistrust and, as I stated before, making it something that is not, like something negative that Black folks have just sort of like glommed onto for no reason. It's there to keep ourselves safe. All right. So I just wanted to highlight some strategies to counteract medical mistrust. So, and the first is I'm going to sort of, like all of this is framed within the context of cultural humility. And so if you've not heard of cultural humility before, it is a stance toward understanding culture, and it requires a commitment to lifelong learning, continuous self-reflection on one's own assumptions and practices, comfort with not knowing, and recognition of the power, privilege, and balance that exists between clients and health professionals. So this is something that can frame interaction of providers and folks who are interacting with patients or clients, that can help to alleviate medical mistrust. If you just, I think cultural humility implies that the sort of interaction is led by the person who it centers, which should be the client or the patient. And also that means admitting that you do not know that everything that this person is going through or bringing to you. So that, allowing people to be the experts on themselves, their identities, and their own health, I think is a tenet of cultural humility. So just some individual tactics for cultural humility, how this could look for you. So cultural humility requires that you do not project ideas onto people. Cultural humility is not just about what you know, it's also about not being distracted by what you think you know. So do not assume that one's personal experience speaks for an entire group of people who share that identity. People are not a monolith, Black people are not a monolith, as they say. All people are a combination of intersectional identities. Also, be humble. So this means be verbally humble, namely. So begin sensitive conversations by saying something such as, if I ask anything that makes you uncomfortable, please let me know. Also, frame the interaction as a partnership. So speaking to this idea of client-centered care, let people take the lead of their own goals and identify what they want for their own health. Also just hold space. So create space for the people to advocate for themselves by asking, is there anything that you think I should know? It goes a very long way in HIV counseling. Right. And so those are individual tactics. So now some institutional tactics for cultural humility and cultural competency. So make sure that forms that ask questions about identity have right and options. So for example, people should be able to write in their gender, their race, or their sexual orientation, rather than checking a box that limits the options for them. You should work to create a space that is both accessible and comfortable to people. Training all staff, including support staff. So for example, if you have gender neutral restrooms in your building, make sure that janitorial staff and everyone in the organization are aware of what that means, are aware of what gender neutral means essentially. And also cultivate a learning culture. So staff should feel comfortable when they're asking for trainings and when they don't have the answer. So make it okay for people to learn so that they can, so ultimately your whole environment will be more inclusive and safer for people. All right, and some strategies specifically for providers. So firstly, find out about your local organization's care quality. So this could look like not only surveying what is going on with the people who work at the institution, but also reach out to community. What are their experiences like with that institution? Encourage healthcare organizations to engage community stakeholders at the beginning. So going along with that, making sure that community voices are uplifted and centered all along the way as you're trying to combat medical mistrust, but also build trust in your community. Advisory boards are also great. Advisory boards can serve the purpose of reviewing patient data and policies for disparities. This is oftentimes where inequities in care and things of that nature are uncovered. And so it's important that you all are having these conversations. Civic engagement is important. Show up in community, uplift marginalized voices, things of that nature. And reciprocity. If the community is providing you with all of this valuable knowledge, like make sure that you're doing something for them. Not only make sure that the care they're receiving is improved and to the standard that they deserve, but incentivize things like, say thank you. Like, some more strategies for providers. So you can teach providers how to respond to mistrust in a sensitive manner while conveying accurate information. Oftentimes the concerns that people have, not oftentimes, almost always, are valid, or they're coming from a valid place in any case. So being sensitive to what people are saying and acknowledging it in a sensitive way is really important. Motivational interviewing skills are important. I know this is something that many of you are probably familiar if you've gone through HIV test or training, but this is really how we can frame interactions with our clients and patients and make it safer for them, and also allow them to sort of speak, to put it plainly. Empathy is really important, as well as reflective listening and being non-judgmental and non-confrontational. And also just acknowledging historical and current context of discrimination as a root cause of medical mistrust. So speaking to this notion that medical mistrust is something that has been inherited and that is totally valid. All right, so that brings me to the end of our content. I see that the chat has been lit this whole time. And so we are going to start with any questions that you have in the Q&A period.
Thank you, Maya. Just real quick before we get into any questions in the Q&A box, I did want to mention to you guys that here at WhatsInTheMirror and BAI, we are always striving for meaningful involvement of those living with HIV. And we're just wanting to know who all here could be a part of that. So we're about to put up an anonymous poll. It is for our funders just to get the information. So if you guys can take the time to just fill out this anonymous poll for us, that would be greatly, greatly appreciated. It should be popping up on your screen now. So we just give a minute, a couple of seconds for that. Then we go right into our Q&A portion of the webinar today. All right, and so I think we have one question in the Q&A, but a question for you, Maya, that came in the chat box, and it was, what does it mean to adjust race, with race in quotation marks? So I'm thinking that was maybe based on something you stated earlier in your presentation.
What does it mean to, what was the word? I'm sorry, I don't think I heard
adjust, ADJUST.
Adjust race. I can't recall if I said that. What, I don't know, like maybe you can, clarify your question in the chat or something like that. But adjust for race. Oh, I know what it is. Adjust for race in like the graphs or some sort of like, like stats. So that just means adjusting probably for like the proportion of people who responded for each race. So for example, if there was like 500 Black people who took the survey and like 20 white people, for example, you would scale those numbers so that they're in equal proportion to get a percentage, essentially.
Okay, perfect. And so we have another question that is kind of still gearing towards your slides. It says that on one of the slides that it was incomplete. It didn't finish the statement. Are you able to read what the slide said? I mean, the question? It said,
Uh,
while we still have ethical standards, medical research still implicitly leaves out Black people and also continues to include. And I guess it just had a quote after that, quotation marks. And they want to know to include what?
let me see if I could maybe find the slide and I'll tell you. But I suspect to, let me see. Stop me if you see it.
Okay.
Oh, here it is.
Right here, yeah.
Continues to include, I guess, bias and racism is what I was leading towards. I'm sorry, it got cut off. But just include the unfair treatment of Black people and also, yeah, erasure and sort of the advancements that have been made at our expense is what I would finish that with.
Okay, perfect. So we have another question. Is it the same today having Black people as a commodity?
I think it's the same but different. Like, you know, clearly we
Yeah.
have moved on from being enslaved. We've moved past the Jim Crow era. I think that we've seen a lot of examples in present day as how folks have gotten kind of creative with keeping sort of the legacy of marginalizing Black folks alive. So I highly recommend the book Medical Apartheid by Harriet Washington. I think she does an amazing job detailing sort of the present day like atrocities that are still being committed that have led to medical mistrust and just how Black folks are still mistreated in medical institutions. So yeah, I think, the same but different. I think a lot of the racism that we have seen has not necessarily gone away. I think that it has morphed, rather.
Okay. So we have a question in the Q&A from David. And so he states that I am working on a research project where a lot of those interviewed prefer having a Black African-American practitioner. Is there any information or resources that are making pathways for Black and African-American medical students more equitable?
That I don't know. I'm not necessarily an expert or at all a part of like academia or anything like that relating to medical science. I hope so. I think that looking at I think that's like actually a really important part of like holding institutions accountable is making sure that those programs do exist. And because there's definitely a dearth and a lack of Black medical providers, as you stated, and also like we see time and time again Black folks asking for that. So yeah, I'm not sure to answer your question, but I hope so.
Yeah. And so it was interesting because I have a question to ask you, Maya, that I knew this topic was happening today, and I was watching. I had downloaded BET Plus, of course, another app for another show, and it had a documentary talking about Black women and infant mortality rate and about medical mistrust. And I just really just landed on this documentary. And one of the things around that documentary was this idea of like pain and like Black people being being able to handle pain more than other races. And so I know that I've heard other like comments that even in like medical books, there is like nurses books that like explicitly says that different ethnic races can handle different pain levels than other ethnic races. What do you feel? What have you heard around like this idea of pain and medical mistrust, like from practitioners and nurses and stuff like that?
Yeah, thank you for bringing that up. That's real. Even today, if you look at medical students. Like there's been a study of medical students, and half of them who were surveyed indicated that they believed that there's different levels of pain tolerance that exist on the basis of race. So namely, Black people can tolerate more pain. I think, in talking about like Anarcha and sort of the medical experimentation that slaves endured, enslaved people endured, oftentimes that was given without anesthesia too. And so there's definitely a history to it. We see time and time again, things such as like not as effective treatments are given as readily to Black folks as well. So oftentimes folks will be sent home with some sort of inadequate intervention for a problem that they came into the emergency room with, and they could have essentially been administered like a more like a better intervention, a more fitting intervention. Like, but we see people like be sent home with Tylenol and stuff time and time again, right? So speaking to that pain tolerance, sorry, someone at my door.
And so
sorry, working from home.
it's fine. We got about 10 more minutes. And if we have any more questions in the Q&A box, yes, and we love dogs. We definitely understand. And I see someone is like putting more information in the chat box around medical mistrust. And so, yeah, let's see if I can see more questions. If there aren't any more questions, then we can, if Maya had any last few comments to give to our audience today, and we can have a great afternoon and prepare for the next one next month. Yeah. And the recording will be available for everyone after maybe a couple of days later on the YouTube channel at Black AIDS Institute YouTube channel.
And if you have any questions that come up after we sign off here today, feel free to email me at maya.m@blackaids.org. Happy to engage further around this. And thank you for having me.
Thank you. And if you guys want to reach me in any way, you can reach Daniel at WhatsInTheMirror.org. Definitely follow us on our website, WhatsInTheMirror.org, and whatever social media, and continue to support and follow Black AIDS Institute as well across all social media. And you guys have a great afternoon, and thank you for joining us.